So, I'm trying to give a small update of where are we today in TAVI and what are the innovations that we are having. These are my conflicts of interest. So we know that TAVI has been introduced initially for inoperable patients, but today we are treating more and more younger and lower risk patients, and we are considering new indication, and all of that is leading us to the question about durability. So who in reality are we treating? If we look at the updated ESC guidelines 2025, we see that we have decreased the cutoff age to send the patient to consider TAVI actually to 70 years. So today a tricuspid valve, severe aortic stenosis, and a patient above 70 should be considered first for TAVI and then discuss surgery eventually if there are any compelling indications. Younger patients less than 70 could be considered for surgery, but we always have this gray zone where we need to discuss about what's happening. The non-transfemoral TAVI has been upgraded. It used to be a 2B indication, and today it's a 2AB, so it's a good level of indication. So the more we go, the more we are treating patients through TAVI. It's not the same scenario in aortic regurgitation management. As you know, we are using most of our devices in the aortic regurgitation, but there are very few devices that are actually dedicated to AR. So for now, it's still a 2B recommendation, and it's really for patients who are not candidate for surgery. Now, if you look at the real-life situation, we are looking here at the 2022 publication from the US. As you know, in US, the cutoff is 65, but those guidelines were published in 2021. So here, this was even before the guidelines. What we see is actually the number of patients we are treating is increasing, and particularly in the 67, 65, 80 years old, we see that we are treating more and more of those patients. So we are treating really a young population. 65 to 80 years old account for around 45% of patients actually treating by TAVI in the US. So are we taking risks by going to younger patients? So we had this publication from Evolute Low Risk. So Evolute was this study included around 1,400 patients, and they were randomized to undergo TAVI or surgery, and the result was pretty reassuring at 5 years. So we see that there was no difference in terms of stroke, of mortality or of mortality alone, or of the composite endpoint. Partner was done with with the balloon expandable valves, the Edward valves, and here we had a difference initially, but when we look at 5 years, we were seeing that the difference between the two, between TAVI and surgery, is becoming really small regarding the composite endpoint, and there were some concerns whether there will be an inversion of the curves. And this year we had the publication in New England by Martin Leon of the results at 7 years, and we see that the difference is still there. The curves did not invert as was discussed at some point. So we are pretty sure that even at 7 years we are safe with continuing with TAVI. Now if you look at how actually the valves are acting at 5 years, here we see that actually the gradient, and here it is Evolute Low Risk. So as you know, Evolute is a supraannular valve, and it offers, and we see it here, a larger orifice area and a lower gradient compared to surgery at 5 years. So pretty reassuring again results, except regarding the more than mild regurgitation, which was a little bit higher, and it was higher with TAVR. Again, these are all generations of TAVR, so things have improved today. Now, if you look at what really matters, which is reintervention, there was no difference in reintervention between the valves, no difference in terms of endocarditis and thrombosis. So basically, again, safety is here. Portico is the valve from Abbott, and it has also an advantage regarding the hemodynamics. And if you look, we have single digits gradients, including at 5 years of a follow-up. So again, pretty reassuring. There was no difference in terms of bioprosthetic valve dysfunction and valve failure. Now, if we go back to partner 3 and we look at what happens at 7 years, here we have 89% of the patients that had available echo and available hemodynamic. The results were good. We have a difference in terms of atrial fibrillation. Of course, it was more frequent in the surgery group, a little bit more thrombosis in the TAVR group, most likely because those patients were not under anticoagulants since they didn't have their AFib. Reintervention, again, no difference. In terms of gradient, always the same, and in terms of valve area, here we are working with the Edwards valve, so a little bit higher gradients, but no difference. We could have suspected these results with the Notion 10 trial that was published earlier in 2024 and was pretty reassuring, but it was criticized because we had a lot to follow up. About 1/3 of the patients were only followed up till 10 years, but the results were pretty good. So I guess we can say that we are not taking real risks in going into lower risk and younger patients. Now, if we even look at the real outcomes, which are the structural valve dysfunction, again, there was a difference in favor of TAVI, so even more reassuring. Now, what also have changed was time. Again, it was the indications, the real practice, but also the way of practicing the procedure. So now TAVI is doing under local with sedation in most centers with a duration of less than an hour, almost 30 minutes, mainly femoral access, of course. But also we have learned the importance of not only wanting to get the patient out of the procedure alive. What we want today is to be ready for the next procedure and to be ready to have the patient live 20 years with this valve. So what we do understand today that those patients are going most likely to have a PCI at some point, and we want to have the commissural alignment to improve the future access to these coronaries. Commissural alignment has also showed favorable for central leak, paravalvular leak, and also for potential redo TAVR. It's better to have done the commissural alignment initially. So we are more working on the procedure as it's the first procedure of the patient, and we are already considering that there will be a second one, and we have to have optimized the initial procedure. Another thing that we understood is the importance of real expansion of TAVI. It's funny, but we are following almost the same scenario of what happened with coronary. Today we are talking about the expansion of the apposition and the expansion of our stent, and it's the same that we are having with TAVI. We want our TAVI devices to be really expanded. We want it to be symmetrical, and this will decrease the incidence of HALT, of thrombosis of those valves, and potentially increase the durability of the valve. So are we having new indications regardless of the age and the risk? Actually we are. So one of the questions that was risen was there a difference if we should we wait for the patient, or if they have moderate AS and signs of heart failure, should we go for TAVR? And this was a randomized trial from 2024. What it showed is that actually there was no real difference in the composite endpoint, but there was an improvement in quality of life in those patients. Another question that was asked is whether we should treat the patients who are still asymptomatic despite having a severe aortic regurgitation, aortic stenosis. The more and more we are being aware of the risk of cardiac damage and the need to avoid it. So what we've seen here, there was a real difference in favor of TAVR. So you see that the composite was lower with TAVR, and even though we didn't have a real difference in terms of death in those patients. What was the most important is the need to conversion to replacement, which is quite expected. I mean, if we don't treat the patient initially, we will have to treat them at some day. So there was a lot of switch from the procedure to from follow-up to real treatment. So in conclusion, the TAVI landscape has changed a bit over the last years with younger and lower risk patients and even new indications that we haven't considered before. And again, the more we go, and this was also highlighted in the guidelines today, that we understand that we need to optimize the initial procedure and consider it as only a first procedure. Thank you for your attention.